847 reminds us of 1947 when we got the freedom. So how to get freedom from back pain? I invite Dr. Rahul Gupta. He is from my alma mater and he has introduced himself. His interests are minimally invasive brain and spine surgery, endoscopic skull-based surgery, endovascular neurosurgeries, complex brain tumor and neurovascular surgeries, pediatric neurosurgery, vascular neurosurgery. You name any neurosurgery, he is there. Please come.
Thank you, sir, for those kind words, and I welcome all the delegates for this meeting, and I thank the organization for giving me a chance to present some of my things in front of you. And this will be on spine health and backache. So everybody should sit upright because that is most important to prevent back pain from happening. And everybody suffers from backache at some point of their time. So it is very important for us to know what leads to backache, what are the various remedies, and how can we avoid surgery, and when should you refer a patient of back pain to us for surgery. So that is important. So we know about spine health. Backache is a pain which occurs anywhere in the back, starting from the neck region to thoracic region as well as the lumbar region. We all know that the cervical and the lumbar region are the mobile segments of the spine. So they lead to more of backache because of degeneration changes or due to strain and common trauma. So the pain usually originates from muscle, joint, nerves, bones, ligament, disc spaces and even joint capsules. So back pain is not just a disease, but it's a constellation of symptoms. It can be acute, subacute or chronic, and it can be neck pain, middle back pain, lower back pain, or even coccydynia is very common when there is an injury to the coccyx. Some might have seen some patients who are suffering from coccydynia. And there can be dull pain, sharp pain, piercing pain or burning sensation. So why spine is important? Why do we have backache? Spine is very important to make us erect, which differentiate us from most of the animals. And also this back is responsible for our bending, picking object from the floor, doing various activities. So one is stability, another is flexibility. So both the actions which are contradictory are being done by the spine. That is why it is very much vulnerable to pain or any trauma. We all know from our anatomy classes, ma'am is here, that we have the spine, the cervical is the mobile area, lumbar is the mobile area, and the thoracic area is where the rib cage is, it is not so mobile. So it is less vulnerable to a degenerative change, but more vulnerable to other pathological diseases like tuberculosis or tumor. Then there is of course sacrum and coccyx. So this is the most important part, that is the disc, because most common problem leading to back pain is the disc problem. Disc is basically a cushion which is between the two vertebrae, which prevents the two bone edges from rubbing against each other, thus to prevent the degeneration. But when there is a problem or there is a stress on this vertebral disc, intervertebral disc, then it leads to pain. The pain may not be per se because of the disc bulge, but maybe because of the increased pressure, because of the decreased height, then leading to problems in the ligaments, joints, and sometimes the disc protrudes out and compresses the nerves, leading to sciatica type of pain in the lower limbs, or the pain in the arms or in the shoulders in the cervical region. So these are the various forces which are acting on the spine, which are against us, and we have these type of acute injuries like trauma, fall from height, road traffic accidents. We can have chronic backache because of the bad posture. So the most common reason for backache is a bad posture or any bad activity which we are doing repeatedly, which our back is not able to tolerate and leads to problems. So we have to identify them and we have to prevent them. This is something what is happening, especially in the IT sector. People are becoming apes again, but previously the apes had a lot of muscle bulk, they had a lot of exercises, but now without exercise, eating junk food and having this posture, they are vulnerable and they are good for us because they are our patients. So back pain, when to seek help? The most common back pain is the back strain, which occurs due to a bad posture, a sudden trauma, where there is an injury to the muscle or the tendon. It requires just bed rest, analgesics, hot fomentation, local gel, and can be treated by anybody. Within 72 hours to 7 days, it becomes alright. But when it is beyond that, patient has to consult a spine specialist. So the spine specialist has to be consulted, or the patient has to be referred to a spine specialist if there is a weakness or numbness in the nerves, that is involvement of the nerves. Whenever there is an involvement or compression of the nerves, patient has to meet a spine specialist, or there is a fever along with back pain because it can be a sign of infection like tuberculosis. It's so common in India. There can be a new bladder ball involvement because of the nerve compression. We need to decompress the nerves, otherwise this will become permanent. Pain is increasing with time, not relenting to the medication or the rest which we are doing. Or there is a history of a chronic disease like malignancy, diabetes, cancer. So in that cases, the patient has to, there may be some subtle signs which may be missed by a general physician. Patient has to visit the spine surgeon. So the treatment offers, I write as 3 P's. It can be pills like medicines, it can be physiotherapy, or it can be precautions or bed rest. But sometimes, around less than 2% of the patients, the backache may be due to a serious illness for which we have to investigate and may require a treatment which can be medicines, which can be something else, or even surgery. So the investigations, when we talk about investigations, there are a plethora of investigations which are available, but we have to be very clear which investigation has to be done. We have to be rational about it. So the most important thing is the first, a good clinical examination. Once we do a good clinical examination, we know which part to examine and what sort of investigations to be done. I repeat again and again at most of the forums, MRI is the most important investigation to diagnose any disease of spine. So please don't refrain from getting an MRI done even at the drop of the hat, even when the patient has come to you for the first time, because this will be able to diagnose even minor problems. We might miss minor problems if we do not do MRI. Clinical examination can sometimes be deceptive. So MRI of the spine is very important. 95% of the cases can be diagnosed by plain MRI. But if we supplement with a contrast MRI, then we can achieve 100% result. A disease cannot be missed if there is a contrast MRI and it's normal. So the chances of missing a disease will be less than 0.1%. So contrast MRI of the spine, but definitely you have to be rational. Whether it has to be cervical spine MRI, dorsal spine MRI. Many people write screening of the whole MRI. Sometimes patient present with very vague symptoms. We can even get a screening MRI of the whole spine. But please, for any back pain which is lasting more than 72 hours or 7 days, go for MRI so that we can at least rule out. It is a harmless investigation and can be repeated n number of times. X-ray. X-ray is an important investigation if we are suspecting any trauma, if we are suspecting any tuberculosis, if we are suspecting there is a disruption of the bony alignment. Otherwise, X-ray doesn't have a very big role. Definitely before surgery, X-ray should be done, especially if we are putting an implant, so that we can compare with the post-surgery X-ray also. Then we have other scans like CT scan, which are specialized investigations. We can go for CT myelo if the MRI cannot be done. If there is a metallic implant made up of steel in the body. We can go for nerve conduction studies if we want to know the status of the nerves, or we are suspecting a non-compressive myelopathy. That means there is no disc problem, there is no bone problem, but there is some problem with the spinal cord, which Dr. Nitin would like to address. But we have to do nerve conduction studies, we can do myelograms, we can do bone marrow studies, we can do PET scans, we can do the DEXA scan to know about the osteoporosis status. So these are the various investigations, but I repeat, MRI is most easily available investigation, most informative investigation, most least invasive investigation. This has to be done. These are the surgical options which we offer, like microdiscectomy, like endoscopic discectomy, correction of deformity, bony decompression, bony fusion with the help of screws, rods, plates, removal of the spinal tumor, and various pain procedures like sacral and foraminal blocks. So we are talking about Fortis Hospital, Noida and Escorts, where we do the surgery for spine, exclusively being done by us. We have a large team for that. This is the operation theatre. We do all the spine surgeries with the help of microscope. And now we have added neuro navigation. We also do neuro monitoring in cases where we think there can be involvement of nerves or spinal cord. This is the setup of the operation theatre. We have a special spine table, we have nurses, we have technicians, we have anesthetists, we have a microscope which has a screen. Then we have the view box where all the X-rays and MRI are displayed, so that we can have the complete environment where successful and good quality spine surgery can be performed. Now, there is a major myth, even among doctors. If I speak to some doctors here in private, they will say, no, spine surgery नहीं करवानी, क्योंकि spine surgery करने के बाद आदमी चल नहीं सकता, उसके पैर खराब हो जाते हैं. This is a major myth which is prevailing for a long time.
Not any disrespect for orthopedic surgeons, but for till 20 years ago, most of the spine surgeries was being done by the orthopedic surgeon, and they were not seeing the MRI because it was not so available, and only one procedure was being done, that was laminectomy. But gone are those days when only laminectomy was done. Now we have so many long list of surgical procedures you can do. So they have given results. So because of the availability of operating microscope, endoscope, neuro monitoring system, neuro navigation, specialized operation tables and the attachments, new technology and techniques, and instrumentation like screws, plate, cage, all these things have changed this whole scenario. Till 20 years ago, where 5% patients were all right after surgery, now less than 5% patients may have a problem after surgery, especially if they have a spinal cord lesion or an injury. And better diagnostic methods. It is again very important. The good quality X-ray, MRI, CT scan can show us everything what we want to do, what we are supposed to do, even before surgery. Before putting the knife, we know what we are going to do. And what I forgot in this is good anesthesia. We get a lot of help from the anesthesia chaps who give us so smooth anesthesia that patients do not have much of blood loss and surgery is very smooth. So all these things are helping us. So the spine surgery has become very safe. More than 80% of the people get at least 90% improvement. 5% may remain the same. Less than 5% may become worse after a spine surgery. So don't refrain from sending your patients for this. Now, spine pathologies can be distinguished among various categories, including like congenital, trauma, degenerative, infective. This is one of the patients, 34 hours old, we operated upon for spinal dysrefism. You can see this lumbar meningomyelocele. And these are the congenital malformations. We have scoliosis, we have the spinal dysrefism. This is spina bifida. This is what I told you, we operated. This is the cervical meningomyelocele. You can see the child. Child is less than 1 month old, and we operated upon for this meningomyelocele in the cervical region. Patient is happy. Then we have congenital problems in the craniovertebral junction. At the place where our head is resting on the spine, there can be an atlantoaxial dislocation at this region. You can see how this spinal cord is pinched because of this bone which is dislocated. So this is an atlantoaxial dislocation. We operate with the help of decompression and fixing it with the help of screws, plates, and this is how the patient looks after second post-op. If there is a fracture to the odontoid, then we can put odontoid screw like this in this patient. Then cervical disc disease is very common. We have operated about more than 1,000 cases of cervical disc disease at various levels in the cervical spine. Like for this example, 27-year female, pain in the back of neck, very common, cervical spondylosis. Radiation of pain in the arms, forearms. Then there is a nerve compression seen on MRI. This is how the MRI looks. This is the disc bulge. We operated upon her. This is how the discectomy has been performed. Then we put an implant in this case, and this is how the implant looks. Scar is hardly visible. Usually these patients, they do not come after second follow-up. After 1 month, they don't come because they are cured of the disease. Pain has gone, disease has gone, just free of the disease. They never come back. Then we have 2-level disc protrusion. Sometimes we go for compact knees. We put this cage, we fix it with plate and screws. This is the scar which is hardly visible. Operated upon many doctors, many models, many people who are with the social work, young patients, but they do not have any scar, they are happy. Like this patient, he wanted an artificial disc. I do not have so many pictures after 1 year, 2 years because they don't come at all. They never come. This is the artificial disc which I have placed in one of the patients. Sometimes if there is a multi-level disc disease, we go from behind. Decompress and fix from behind. These are the screws, lateral mass screws which are put from behind. Another patient, thoracic spine trauma, tuberculosis, prolapsed disc, ossified ligament and congenital scoliosis. These are common in the thoracic spine. So when we talk about thoracic spine, this is a spine tumor case, 40-year female from Kashmir with pain. She came with this X-ray. You can see this. Anybody can point out this X-ray is diseased. It is not normal as compared to other vertebral body. And this is the MRI which we see. On MRI we can see the tumor. This is the tumor. This is the aorta. The tumor is abutting the aorta. We removed the tumor, put a cage, fixed it with screws. It was plasmacytoma. Patient was happy after 6 weeks. Went back to Kashmir. Lumbar spine. We have degenerative changes. Trauma, congenital, PIVD, prolapsed disc and infection. Degenerative is very common with aging. It may occur even in 50 years or even at 75 years. And we have seen some people at 80 who are having a normal healthy spine, no problems at all. So it is just congenital or maybe because of the wear and tear which you have over the time. This is the picture which shows how the disc degenerates. On the top we see a normal disc, then this is a degenerative localized disc, this is a bulging disc, this is an extruded disc. there can be thinning of the disc space, there can be irregular margins, the bone getting eroded because of the degenerative changes. Like on this MRI, we can see how the discs are normal. This white color central portion, blackish, and this is the body. You can see this is a normal disc. Then this is the disc, which is disc space is reduced, sub-bulging of the disc is there, degeneration of the disc. Then this is the exclusion of the disc. Like in this case, the disc is coming out, compressing the spinal cord. These people require surgery. Like for example, in this case, the disc is coming out, compressing one nerve root, sciatica-like pain. We can go for microdiscectomy, we can go for endoscopic discectomy. We localize the lesion. This is a disc which has come out. The scar is hardly 2.5 centimeters. And patient is cured of the disease. These patients, they walk out of the hospital after 48 hours, and usually they do not come after 1 or 2 times. But after simple microdiscectomy, definitely they need to take some precautions so that there is no recurrence. Then we have the fractures. We can have compression fractures, wedge fractures, burst fractures. Sometimes the fracture is compressing the nerve root. Sometimes it is just the vertebral body which is involved. So all these fractures have to be treated. Like in this patient, the young patient who had multiple fractures of the lumbar spine as well as sacrum, you can see how the sacrum is broken, and this is the sacrum which is broken on both the sides, and we did this fixation with the help of sacral plate as well as lumbo-iliac fixation. This is the X-ray which looked like, and this is 1 year follow-up. Patient is having a normal life. So these patients with trauma who do not have a significant nerve or spinal cord injury can again be cured of this disease, and they can lead a normal life after a successful spine surgery. We can go for minimal invasive percutaneous fixation where we put multiple incisions and put these screws, and this is how the screws and the cage look like, and the patient's scar is hardly small one, and patient heals very fast. Then in elderly patients, there can be osteoporosis or there can be a tumor which may lead to a pathological fracture. So in these cases, we have a very important and very easy minimally invasive procedure known as vertebroplasty or kyphoplasty, which can be done immediately 1 or 2 days after the fracture, and patient pain goes like magic. So this is one magic which I have seen in neurosurgery in my life, where like in EDH, you must have heard, extradural hematoma in the brain, you remove it, even if the patient is in coma, patient stand up within a few days and leads a normal life. Similarly in spine fracture, if we are doing kyphoplasty or vertebroplasty like this, patient walks out of the hospital next day without any pain. Definitely some pain because the soft tissue may remain, but the fracture pain disappears like a magic. So this is what we are doing. Sometimes if there is a nerve compression, we have to go for decompression and fixation. This is how the vertebroplasty X-ray looks like. And these are the various holes. Like in this patient, at 6th level, we had done in 2 sitting. This was his spine, this was his back. After some time, this is the patient. So we treat these patients even with cancers, like fixation with the help of cement as well as screws. Another patient of tubercular spine, she had a pain, cannot sit or stand, radiating lower limb. On the MRI, this is the classical picture of tuberculosis. The whole of the bones are eaten up. There is some pus collection also. This is on CT scan. You can see how the bone is eaten up. And this bone, you can see hardly this bone is there because of the tuberculosis process and what to do. So the main treatment of tuberculosis is anti-tubercular treatment. But if there is a neurological deficit, if the pain is worsening, there is too much of pus, there is a kyphotic deformity, we have to go for surgery, which is decompression and fixation, and patient's ATT has to continue. So this is, in this patient we had a fixation, we had put a cage, patient started walking in 4 days, ATT continued, patient's pain disappeared within a few weeks. We got the tissue for diagnosis, because it is important even when we are suspecting a pathological fracture, tuberculosis or tumor, we should have a tissue diagnosis. If we do not have a tissue diagnosis and we misinterpret the MRI and treat tuberculosis as tumor or tumor as tuberculosis, the patient can have serious problem. So now the strong recommendation is there. Even Professor Tully, everybody must be knowing about him. He is a senior professor who has done a lot of work in spinal tuberculosis. He is facing some judicial charges because he misdiagnosed some tumors, treated them as tuberculosis, and tumors spread and became problematic for the patient. So nowadays, transpedicular biopsy or a CT guided biopsy, FNAC, is quite mandatory to diagnose a tumor or tuberculosis before labeling them as that. Definitely, we can, if we have the slightest suspicion of tuberculosis, we can start ATT because that will not interfere with our diagnosis, but we have to have a tissue diagnosis. So this is the patient. Neglected spine tuberculosis can be something like that. We can see a lot of beggars in Delhi who have this hump there. So these are the cases of neglected spine.
Dr. Rahul, can you just
wind up because other two speakers are there.
We have so prevention is better than cure. We have to do all these things to reduce the reduction. We have to do a lot of exercises. These things are very important that we have to take care of our ergonomics. We should at our workplace we should have all these gadgets and all these things according to our posture so that we do not develop back pain. We have to do these exercises if there is a back pain. And this is last case which I want to present. We are proud of it. This is a 103-year-old lady who had a trivial injury at home. She had a fracture, severe pain. She could not even talk. We did vertebroplasty in this patient, kyphoplasty. This is first post-op day. This is as follow. She is happy. So what do an elderly patient need? Elderly patient wants to go to the toilet. That's most important thing because no son or daughter will take care of her or him by cleaning his potty and susu. So the patient has to walk up to the toilet, and after this miraculous procedure of vertebroplasty or kyphoplasty, patient can at least go to the toilet immediately after the procedure. Thank you very much. This is my team.
Very good.
Thanks, Rahul. It was a good presentation on all pathologies of spine. Our next speaker is Dr. Nitin. He will be talking on a very controversial and interesting topic, status epilepticus. It is very important because we do not have a large data, evidence-based data on this topic, and this condition has varied etiology, and if not detected on time, it can carry a very high mortality and morbidity. So without much ado, over to you, sir. Let's learn from his experience.
Hello everyone. This is a very important topic, status epilepticus, because we know that it is a medical emergency, and I will try to discuss in brief as much as possible what are the recent definitions which has been changed in status epilepticus and how to manage these patients in a proper way. So first of all, we know that it's a medical emergency, and status epilepticus is a medical emergency with a high morbidity and mortality. Overall, the incidence is around 18 to 41 per lakh of populations, and the mortality approached 20% if the patient is having a generalized status epilepticus associated with a generalized tonic-clonic syndrome. So, seizure, as we know, is a transient occurrence of sign or symptom due to abnormal, excessive or synchronous neuronal activity in the brain. So, first of all, the International League Against Epilepsy has first of all given the definition of status epilepticus in 1970. So before that, in 1973, Meldrum in his study found that, in his study in baboon, they found that whenever in baboon, if the seizure was continued for more than 82 minutes, there was irreversible neuronal injury. So after that, the Epilepsy Foundation of America has given the duration for status epilepticus of 30 minutes. But we can see that if the patient of seizure is having continuous seizure activity for 30 minutes, there will be a significant brain damage. So for that, and as long as the duration of the seizure will increase, the prognosis of this patient get worse. So Lostin in 1999 proposed a new definition that all adult and children who are older than 5 years of age and if the duration is, if the seizure is continuous for more than 5 minutes, or there are 2 or more discrete seizures in between, the patient is not having recovery in consciousness level, it should be labeled as a status epilepticus. So initially which was 30 minutes, now it has come to 5 minutes. So, and the ILE task force 2015 had given, had classified status epilepticus into a conceptual definition and an operational definition. So now the new concept of time T1 and T2 has come. The T1 time is the time that is a duration of 5 minutes within which we have to aggressively manage the seizure, and T2 is the time that is 30 minutes. If we have to be more aggressive before this T2 time, because if the patient, if this T2 time has been crossed, the chance of irreversible brain injury is high. We can see this. Now the operational definition is for tonic-clonic seizure. T1 time is 5 minutes. It means that if the seizure prolonged more than 5 minutes, it can be continuous further. And the T2 time is the time if within 30 minutes we does not stop the seizure activity, it can result in neuronal injury, neuronal death, and it can result in functional deficits. So the pathology of status epilepticus is that within seconds there is protein phosphorylation, ion channel opening, neurotransmitter release. Within minutes there is decrease in GABA activity and inhibitory GABA activity, and increase in NMDA and the excitatory neurotransmitter are increased. And after that, within minute to hour, excitatory substance P and the are increased and the inhibitory neuropeptide are decreased, and within days and weeks, if the seizure is not controlled, there can be change in gene expression, can be DNA methylation, and there can be abnormal regulation of microRNA, which can result in permanent development. So this is the classification of status epilepticus, which is new, where they have divided epilepsy in based on semiology, etiology, EG, and age. So in that there is axis 1 if the patient is having motor symptom and impairment of consciousness, and as opposed to those patients with non-convulsive status epilepticus. So this is the axis 1. Now the classification has included convulsive status epilepticus with prominent motor symptom. There can be convulsive status epilepticus, myoclonic status, focal motor seizure, tonic, and hyperkinetic. And if the patient is not having any prominent motor symptom, then it can be non-convulsive status with coma, and it can be non-convulsive status without coma. So now they have also divided it based on etiology. Status, most of the status epilepticus are called symptomatic when there is a reason behind the seizure activity. Acute status epilepticus can occur after stroke, after some intoxication, after malaria, encephalitis. Remote can occur after an post-encephalitis syndrome or after trauma or post-stroke. There can be progressive status epilepticus that occur in progressive myoclonic epilepsy and after brain tumor. And there are also unknown or cryptogenic causes. So now the third axis is based on the EG. So, and the fourth axis is age. So now the new classification has made a lot of changes, and in this age also there are some epilepsy which is common in neonates, some in infancy, some in childhood, some in adolescence, and some in elderly more than 60 years. We can see this is a classification. It's a long list for a particular status epilepticus in a proper, according to the group of patients. We will not go into detail in this thing. Now we will discuss the management of status epilepticus. So whenever we are dealing a patient of status epilepticus, as we have seen the definition, if persisting for more than 5 minutes and or 2 seizure episodes in between, the patient is not having a consciousness level. So first of all, our main aim is to protect the airway, to ventilate the patient, and to make him hemodynamically stable. If the blood sugar are low, give thiamine followed by glucose. You can give a dextrose solution if the seizure has occurred because of low glucose level. So the first step is we have to manage the hypoxemia, hypotension, hypoglycemia, and fever, because these things reduce the substrate delivery to brain and increase the metabolic demand. So these things should be managed. So if required, a head CT can be done, routine blood tests, metabolic panel, calcium, magnesium, and toxic screen if history of any taking any medication of with toxicity. And if the patient is having seizure, you have to do the anti-epileptic drug levels. So all patients should be immediately, in this patient EEG should be done. For a comatose patient, it should be continuous EEG monitoring should be done for 48 hours. For non-comatose, it should be at least 24 hours. So now in which patient we have to go do a CSF exam, and we don't find any etiology for their status epilepticus. In that, based on the history, investigation, neuroimaging, in those cases we can go for a CSF. If there is a no prior history of any seizure or epilepsy and presenting to us with status, we can go for a CSF. If the patient is having fever or at the time of presentation or hypothermic, or the patient is having a suppressed immune system, in those cases also we can go for a CSF examination. So generally we have to avoid antibiotic like fluoroquinolone, penicillins, cephalosporins and carbapenems. Now the first line of agent which we use to terminate the seizure, first we have to terminate the seizure. Second line of agent we have to use just with the first line fail and also to prevent the recurrence of seizure. And the third line agent are used for refractory status epilepticus. The definition we will discuss later. So the most important medicine when the patient came to emergency is either give a lorazepam, midazolam or diazepam. So ideal, the most effective medicine I will think, I will say it is lorazepam, because the duration of action is long as compared to midazolam and diazepam. So lorazepam is better than diazepam when we give in emergency because of the longer duration of action. Because we can say diazepam enters the brain within 10 seconds, but drug levels significantly decline after 20 minutes. While when we talk about lorazepam, it reaches it effective within 1 to 2 minutes. Onset of action is there, but duration of action can be up to 2 or 12 hours, because the chance of recurrence will be less. So these are the doses of diazepam, lorazepam, midazolam. Will not go between this. So as we know that these benzodiazepines could relate to respiratory and circulatory collapse, specifically in older age patients. So we should always give the infusion at a slow rate, and it should be accompanied by fluid expansion. And we should always think that the uncontrolled status epilepticus can cause a severe injury to brain. So we should not underdose the patient, thinking that the patient can have a circulatory collapse or airway compromise, because the benefit of these drugs are far better than the damage which is caused by the status epilepticus to the brain. So now the second line of agent should be given to all patients immediately after the first line, whether or not the status has been aborted by benzodiazepine. And the importance is that these medications prevent the recurrence of seizure. So even we have given midazolam or we have given lorazepam, after the whether seizure subside or not, you have to give an antiepileptic to this patient. Second line antiepileptic. The common antiepileptic we use are phenytoin, valproate, levetiracetam, phenobarbital and lacosamide. And the medicine drug of choice will be according to the patient profile, age and other comorbidities. These are the different doses. And this is the purple glow syndrome which can occur with phenytoin. So always give a slow infusion and should be given in vein which has a little bit larger bone than narrow veins. Now what is refractory status epilepticus? So even after giving benzodiazepine and a second line anti-epileptic, the patient is still having seizure, then that is called refractory status epilepticus. So it has a high, generally 23 to 43% of the patient can progress to refractory status epilepticus. So mortality rate is around 70 to 39%. Say that is 3 times higher than rate of non-refractory status, and most of the patients who go into status epilepticus are generally those patients who has a history of encephalitis and or patient is having hypoxic injury to the brain. So earlier the treatment, better will be the prognosis of this patient. So for for refractory status epilepticus, we use third line agents which are anesthetic agent. We know that midazolam, propofol, pentobarbital. But ideally we should start with midazolam, propofol, because their side effect profile is is lesser than when we compare with phenobarbital. So we should start with midazolam or propofol if the patient is not getting this patient still having seizure after starting of these infusions. Then we have to go for phenobarbitals. So we can see the mechanism of action: propofol, barbiturate acts through GABA agonist and NMDA antagonist activity and act on calcium channel. And propofol has action on all the receptor, and midazolam mainly act by GABA A agonistic activity. So different doses. There is a important propofol infusion syndrome we should always keep in mind when we are giving a patient infusion of propofol, because it can cause fatal cardiorespiratory collapse with lactic acidosis, hypertriglyceridemia and rhabdomyolysis. So generally it occurs in those patients who are co-medicated with steroid and catecholamines. So to prevent this, administration should be over 48 hours. The dose should not go more than 5 mg per kg per hour. And and regularly patient lactate levels should be measured to avoid any complications. Similarly, midazolam has a variable half-life from 6 to 48 hours, and tachyphylaxis can occur when it is given for more than 24 to 48 hours. So it can require dose increase. So it has a hepatic metabolism and may require dose adjustment. So refractory status, if the patient not getting improved with midazolam infusion or propofol, so we can go for thiopentone or pentobarbital infusions. So generally when we are giving this infusion, our main aim is to achieve burst suppression. So whenever we start the infusion, we have to do a continuous EEG monitoring of this patient. And during EEG monitoring, our main aim is to achieve a burst suppression. Burst suppression, in the burst suppression, there will be a burst followed by a next burst which occur at a 10-second interval. You can see this is the typical burst suppression pattern. We can see that this is the suppressed brain activity. After that, we get a burst of discharges, and at an interval of 10 seconds. So when we achieve this burst suppression, we should continue at that dose, midazolam or propofol infusion, for at least 24 to 48 hours, and after that we will start tapering the infusion of this medication, and that should also be done very slowly over a period of 24 to 48 hours. So if the patient even after infusion having seizure, some add-on third-line oral drugs can be used like topiramate, gabapentin, pregabalin, vigabatrin and felbamate. So and this should always be kept on our mind that whenever when we are giving this patient from infusion, the patient should be at least on 2 anti-epileptic drugs at a therapeutic dose to prevent the recurrence of seizure activity. Now, what is super refractory status epilepticus? Super refractory status epilepticus.
Dr. Nitin, kindly wind up.
Okay, sir, just 5 minutes. So, if the seizure, even after giving intravenous infusion for more than 24 hours, the patient is having continuous seizure activity, that is called super refractory status epilepticus. In this case, the drugs which are available are ketamine, etomidate, and inhalational anesthetic like isoflurane and desflurane. So these are the different doses. Other drugs which can be used for super refractory are magnesium, pyridoxine, and sometimes it can be because of some immunological process. Super refractory status can occur. In that case, we gave steroid, plasma change, and IVIG. Ketogenic diet, vagal nerve stimulation, and some resective surgery can also be planned. And there are some studies of transcranial magnetic stimulation and electroconvulsive treatment also in this super refractory case. And last is therapeutic hypothermia can be tried. So to summarize, early status epilepticus start with benzodiazepine, give an anti-epileptic drug to prevent the seizure recurrence. For refractory status, go with infusion of propofol, midazolam or thiopentone, and for super refractory, we have to give etomidate or ketamine. So just one important thing, when we talk about non-convulsive status, if the patient is having non-convulsive status epilepticus and patient is unconscious, the management line is same. But if patient is partial aware or having behavioral abnormality and is having continuous seizure activity in the brain, in those cases we will try to manage the seizures with anti-epileptic drug rather than giving infusions. And there is a new entity called new onset refractory status. Sometimes we get a new onset seizure in a patient, adult patient or old patient with no prior history of seizure, and he started having a super refractory status epilepticus. Generally, most of the causes are idiopathic. Sometimes antibody mediated causes has been suspected. So to say a new onset refractory status epilepticus, we have to rule out infection, we have to rule out encephalitis, we have to rule out paraneoplastic cause, and but most of the cases are cryptogenic. And but the treatment for these patients are generally we can go for steroid and plasma exchange. Thank you.
Thank you for a nice presentation of status epilepticus. I invite Dr. Abhinav to talk about acute stroke, which is actually the domain of neurologists, but somehow a neurosurgeon is going to elaborate and evaluate how to treat the acute stroke, especially surgically. Thank you.
Good evening, sir. Thank you for this opportunity. So, yes, as you rightly said, stroke is predominantly a neurological illness. But then there are times when surgeons get involved, and this is what I'm going to talk about. So, stroke is basically a brain attack. So, as we all know, stroke is one of the leading cause of long-term disability. And a lot of people suffer from stroke every year, and when somebody has had a first stroke, the possibility of having a recurrent stroke increases. And most of the patients have modifiable risk factors, which could be their better control of their illnesses like hypertension, diabetes, chronic kidney disease, coronary heart disease, and dyslipidemia. And a lot of people have modifiable behavioral factors, which are like smoking and their lifestyle and their diet. So, coming on to the types of stroke, so the majority of stroke is a ischemic stroke, and however there is a subcategory of intracerebral hemorrhage, which is the bleeding which has happened in the brain, and a subarachnoid hemorrhage, which is bleeding happened in the covering of the brain. So within the ischemic stroke, there is a lacunar stroke, which is a small stroke, or a non-lacunar stroke. Long-lacunar stroke is generally a cardioembolic stroke or a cryptogenic stroke, where there is a large artery which is involved. And cryptogenic strokes could be embolic stroke of unknown origin or a non-embolic stroke. So coming on to the ischemic stroke, so it is a medical emergency, there is no doubt about that. As time goes by, we are losing neurons as per second. Okay, so per stroke there are around 1.2 billion neurons which get damaged. Per hour around 120 million neurons are getting damaged. Per minute 1.9 million neurons getting damaged, and per second around 32,000 neurons which get damaged. So be fast is one of the mnemonics which has come up. So we have to diagnose the stroke as soon as possible. So if a patient has balance issues, has some eyesight changes, has some face drooping, has some weakness in the limbs, has some speech difficulty, it is time to call somebody. So this is how we manage. We have to identify the stroke, we have to start resuscitation as soon as we see the patient. Now we have to attempt reperfusion of that ischemic brain. So there is this area of brain which is getting damaged, which is not receiving blood. We have to attempt a reperfusion of that area, and there are certain ways to do that. We'll come down to that. So in resuscitation, again, because the brain is getting damaged, we know certain parts of brain are involved in certain functions. So we have to make sure that the ABC is maintained, we have to maintain a BP, we have to check for hypoglycemia, we have to hospitalize the patient as soon as we suspect a stroke, and we have to check his serum electrolytes. First investigation is a NCCT head. We have to get it done as soon as possible, as soon as the patient comes with, whenever a call comes, okay, there's a stroke, we are bringing in the patient, you make everybody aware, you tell the stroke team to get activated, you tell the CT unit, okay, keep everything ready, we are bringing in a patient. So it is easy to get, it is an easy and a quick assessment, it takes around 2.5, 5 minutes, and basic thing is to rule out a hemorrhage. As soon as we rule out a hemorrhage, we see what area is kind of involved. Aspect score is one of the scoring which is made to see the area involved. The best score is 10 out of 10 if we do not see any involvement, and then as the area is involved, we deduct points from that. So we can also prognosticate if it is less than 7 or less than 6, so that becomes a big stroke. And there is a hypertense MCA sign that can also be seen on the CT. MRI brain with angiography is also one investigation which can be done initially to begin with as well. CT perfusion is something which we go on to when we have to make some decisions. So there is this concept of penumbra where actually these vessels which are supplying the brain, they are kind of end arteries. So they don't really have any collaterals. So there is this area which is getting supplied from that one vessel. If that is blocked, the area of brain stops getting blood supply. So there is this pore which develops. So there is irreversible damage. Already it is damaged to an extent that we cannot really salvage it. The blood flow becomes less than 7 milliliters per 100 gram per minute. And surrounding that area, that is the area which gets some supply from surrounding brain, surrounding vessels, and that is functionally impaired in this event, but however it is structurally normal. So if it has a blood flow of around 7 to 12 milliliters per 100 grams, that would indicate that it is still salvageable, it is not lost beyond a point. But if we don't do anything, this area will also get damaged. There is no doubt about that. So we have certain agents. The first agent that we all kind of have heard, that is recombinant tissue plasminogen activator. It is FDA approved. Initially, it was approved to be used within 3 hours of diagnosing a stroke. Now it is safely approved and recommended up to 4.5 hours of initial symptom. When the first symptom appear. So it is the first line therapy in most of the patients. IV therapy, however, has some limitations because recanalization rate, the reopening rate is not that big, not that good when we consider a large vessel stroke. It has been variably reported from 4% to 68%. Now we have a newer molecule which is tenecteplase, which is more resistant to enzymatic degradation, more drug reaches the brain, and it has a greater specificity for the clot also, and it has a longer half-life. Most of the places are using tenecteplase now. Now coming on to what endovascular treatments we have for stroke. The advantage of endovascular treatment is that it offers a more certain and a rapid recanalization when compared to an IV therapy. It has a larger window period. We can use this till about 8 hours very safely, and in certain cases it has been recommended to up to 18 to 24 hours also. And in patients who are unsafe for recombinant tissue plasminogen activator. Disadvantage is, yes, that it has a certain inertia. There is a delay in starting the therapy. The whole team has to be mobilized. The patient has to reach a place where this therapy is available. Also, because there is higher reperfusion, it leads to higher reperfusion injury also and distal embolization. So, in endovascularly, we have two options. We can do drug delivery into the clot itself, which is called as intra-arterial tissue plasminogen activator, which is given. Or we can do clot manipulations where we can go in, touch the clot, remove the clot, we can aspirate it, we can break it, we can retrieve it via stent. So IV RTPA, we go in, So IV RTPA, we go in, we take the catheter up to the block, and then we give the drug directly into the clot so that it causes clot lysis. What we are trying to achieve via IV therapy, we are going to give it directly targeted. So that is one way of giving endovascular therapy. Mechanical thrombectomy is a gamut of things which we do. There is a thrombectomy which we do where we try to break the clot using this Mercy device. There is a thromboaspiration where we try to pull the clot out from the vessel using this penumbra device, or there is this stent assisted thrombectomy where we use some stent to catch the vessel, to catch the clot and to keep the vessel patent also. Now, most of the data prefers that we have to consider both the therapies for most of the stroke patients. We have to give IV RTPA if the patient is fit, give the IV RTPA and then take the patient out for DSA and do the endovascular intervention, because we might not find any block in the intervention, but then if we find a block, then we can treat it further rather than wait for the effect of the IV RTPA. So here I am trying to present a case which is a 41-year-old male. He was an architect. He presented with an acute onset weakness of right limbs. He was unable to move. He was brought on a stretcher from his home, lived in New Friends Colony, got to the hospital within half an hour. Had slurring of speech, and when he came to us, he had no verbal output. So he was brought to the emergency within half an hour. We activated the stroke code. MRI brain was done. It showed that there was a large left MCA territory stroke. We started IV thrombolysis, and door to injection time was 45 minutes. So this was his initial MRI. We can see that there is this developing infarct. We can see no blood flow in the MCA on the right side. And because it was a large vessel stroke and there was not much improvement in his clinical status even within 20 minutes of giving IV RTPA, we decided, okay, we will take him up for DSA and then see what is going on inside. So we shifted him to the cath lab. So in the cath lab, we did a check DSA. We saw that there was a persistent flow blockage. Initially, there was the blockage in the M1 segment. There was no blood flow in the MCA territory. After IV RTPA, the clot has kind of moved distally, and there was a blockage in the branch. So we can see that there is a large area of brain still not getting blood supply. So we went in, we pushed in our catheters, we put in an aspiration catheter, and then we were able to aspirate this clot. And after removal of this clot, this was his final DSA picture, that we can see that a flow was established and blood was getting, all blood vessels were getting filled and reperfusion started. And clinically also, on post-op day 1, patient showed significant improvement. Right lower limb power improved, right upper limb power also improved, speech quality improved, verbal output improved, and patient became conscious, alert and oriented. So from being a bedridden patient who was brought in on a stretcher, he became conscious, alert and started following commands. I'm not sure if you can follow any sound from this, but then this was his status of right limb. This is on first post-op day, still not extubated. So, anyway, so I'll skip the video. And then he got discharged, and when he came back, he was fully independent in activities of daily living. He had no memory deficits. He had slight speech slurriness, but however, he was able to understand and he was able to explain his thoughts. So that is the magic which can happen with acute intervention in stroke, where we can
kindly expedite, please.
Yes, sir, very sure. So there's this confusion about stenting, where we can do a stenting within acute stroke or not. However, it is not recommended. This is our neurocath lab. We are doing all kinds of endovascular procedures where we go in within the vessels. We can block the vessels, we can dilate the vessels, we can open up the blocked vessels, we can block some abnormal growths like AVMs, we can block some, we can deliver drugs directly to the lesion that we want to. We've got, now with the advancement of the technology, we've got different sheets and different catheters and different micro guide wires which can take us to the distalmost vessels which are actually not amenable by open surgery also. And we can deliver embolic agents, we can deliver coils, we can deliver glue, which can lead to avoidance of surgery in these patients. Now, in stroke, decompressive craniectomy comes in a picture, which is a salvageable procedure, which is done for secondary complications of stroke, which is taken up when there is a brain swelling happening because of the stroke. And to prevent herniation, we go in. This is a large infarct where we can see there is a brain herniation happening. So we take him up for surgery, we open up the skull, we leave the skull open, we close the skin only, we remove the bone, remove a piece of bone around a palm-sized bone is removed so that there is a adequate decompression and the brain gets space to swell up, because that is the natural course of illness that is going to happen. So coming on to old strokes, so acute strokes we covered. This is an old stroke, which is, or a recurrent stroke. A patient might be having recurrent TIAs, so that might indicate that he has a carotid vessel problems where we have a compromised blood flow to the brain. So in a symptomatic patient with more than 50% stenosis or an asymptomatic patient with more than 70% stenosis, we have to intervene. The options are endovascular stenting or endarterectomy. In endovascular stenting, we have we go in, we put in a catheter, we go in, we reach the clot, then we pass the catheter beyond the clot, we put in a umbrella device to catch any distal migration that might happen. We go in with a balloon catheter, we try to dilate the balloon, expand the clot, to compress this clot and create a passage, and then leave a stent in the vessel so as to make a patent passage for the blood to go. So that is a way of managing endovascularly the carotid artery stenosis. Coming on to the smaller topic, which is a hemorrhagic stroke. So hemorrhagic stroke could be anything coming from intraparenchymal hemorrhage to a subarachnoid hemorrhage to a intraventricular hemorrhage to a EDH or an SDH. Intraparenchymal hemorrhage could be a pitaminal or a basal ganglia bleed or a cortical bleed. Usually patients are hypertensive on anticoagulants, or they might have some vascular malformation or a tumor bleed. This is one case where in the upper panel we can see there's a large bleed. After surgery we have decompressed, we've removed the bone, we've removed the clot also, and the brain is kind of decompressed. This is an intra-op photograph where we have done the surgery and removed the clot from inside the brain. This is a special situation because it requires kind of holistic management. BP control, which is the reason of the illness, is important. Comorbidities are generally present. These patients could be having CKD, CAD also, so they need to be optimized. These patients might be on anticoagulants or antiplatelets, which need to be reversed and they have to be stopped, and general resuscitation measures are always there. So, depending on the size of the clot, we have these treatment options like conservative therapy or a burr hole or a small aspiration, stereotactic aspiration, or we can do a large craniotomy or an endoscopic assisted evacuation. So these are small strokes. We can see only a small bleed in this lower panel, also a small bleed which we managed conservatively. However, these need to be followed up because they can expand like this in few hours. Or we give RTPA for stroke. We had given RTPA for this patient. Stroke was managed by RTPA. However, because of that reperfusion, there was this bleed which happened. Then we had to go in and do a surgery of decompression. Craniectomy had to be done.
Very good.
So there's this VP shunt which might be needed in case there is a intraventricular bleed. We need to place a VP shunt. Just running around, sir. So the prognosis would depend upon the neurological status, the age of the patient, other risk factors, the site of the bleeding, the KPS score, and whatever time takes for the treatment to be started. Subarachnoid hemorrhage is another type of a hemorrhage where it could be an aneurysmal, post-traumatic, or a benign hemorrhage. It presents as the worst headache of their life. The patient comes with vomiting, loss of consciousness, vocal deficits, or a seizure. CT head is diagnostic. Then we need to find the source via a CT angiography or an MR angiography or a DSA. If we can find an aneurysm, we need to go in and treat the aneurysm by a clipping or a coiling. So there is this clipping where we do a craniotomy and reach that vessel, reach that balloon and try to clip the aneurysm. Here we are trying to apply the metal clip. This is an operative ICG angiography, where we, after putting a clip, we do an angiography to see whether any part of the aneurysm is left or not. We do an angiography intraoperatively, see the picture on the microscope and decide whether we need to re-adjust our clips or apply another clip or not. So, again, running with it. So coiling is another option where we go in endovascularly again and we place our catheter into the aneurysm and release the coil. We deploy the coil. We want to create awareness for the same. Thank you so much.
Thank you, Dr. Nitin.
Thank you.
Now, I would like Dr. Rahul and Dr. Nitin to come along so that they can answer the questions to the panel members and the... I'll ask Dr. Kalra to begin with. Thank you.
Since we are running short of time, I would give 5 minutes each to our coordinators to do their part of the job, and then some time to Dr. Tulsi, and you can be ready with your questions so that we wind it up, maximum by 11 o'clock. The question, I know it is getting delayed today, but please cooperate. Let us finish it by 11 o'clock and then have our dinner. If you want, you can start having your dinner while we are having answer and question session, but don't make noise. We can serve you dinner on your tables if you want. There is absolutely no problem. Over to Dr. M.L. Kalra sir to summarize, to give his perspective on backing.
Dear friends, you must acknowledge this was one of very nice freedom wali baat chal rahi hai, to freedom of back pain. My very good friend Dr. Rahul has very nicely explained about back pain. Posture correction therapy is also coming a big way. So even we have some posture correction belts. Your comment on belts, please.
So my personal take on belts is that belt can be used for some time. The posture correction belts are used for scoliosis patient. Just for simple backing, the belt should not be used for more than 2 weeks because that may lead to hypertrophy or atrophy of the muscles. But the initial treatment, which includes bed rest, is for 1 to 2 weeks. After that, if the pain is not getting relieved, we have to think something else. And active exercises have to be started as soon as possible to strengthen the muscle and to correct the posture.
Usually I used to come just like that, but Dr. Tulsi said that you must come after reading something because you are moderating. So I will ask you about Intercept and Denisumab. Any experience about these two?
Intercept is probably terrible nature. I'm not sure.
Intercept is a procedure done for the back pain.
So Intercept, I am not aware. Maybe procedure is done by either the pain physicians or maybe physiotherapists. If you talk about the treatment for osteoporosis, then the initial treatment is calcium vitamin D supplementation and active mobility. Second is you can go for oral medication, which is in the form of bisphosphonates, which is osteophos or alendronate, which is available weekly or monthly, or even yearly treatment is also available in the form of zoledronic acid. And now new drugs are available in the form of teriparatide, which is a bone forming agent, which has to be taken daily for at least 18 months. And then we have again bone resorptive prevention medicine in the form of denosumab, which can be given, which has to be given 6 monthly for at least 10 years. 10-year studies are available. Then we have got calcitonin, another new drug which again a bone formative plus anti-resorptive agent. Combination of that in a single medicine is also coming up. Probably it will be launched by some company by end of this month or maybe beginning of the second month. So that can be given nice.
Intercept was started by San Diego people. It was some radio frequency ablation to the nerves which were causing pain. It was just like a nerve block. It started some pain physicians. Yeah, right. And Denisumab is a monoclonal antibody to act against the nerve growth factor. And here.
Prevent the resorption.
Yeah. So now I leave the post-lecture.
The second talk, which was taken, I would like the moderator to give his perspective on that talk. you, sir. It was a very comprehensive talk by Dr. Nitin. Really wonderful. So I have a few comments to make, then questions. I think Dr. Nitin, in our country by far, the commonest cause of status epilepticus is drug default seizure, I would say. And first thing. Second thing, whenever a patient arrives in here, we should not forget the ABCs. We should, as he rightly said, we should always check the blood sugar. We should stabilize the patient, protect the airways and all, make him hemodynamically stable, and then we should investigate him any further. Third thing is, I have very good experience with ketamine. Ketamine is a wonderful drug. Ketamine, whenever a patient is especially in super refractory status, so we start the ketamine infusion, we achieve the burst suppression, and then you maintain the for 24 to 48 hours, results are really excellent. Another comment I would like to make that as you pointed out, nausea. So nausea has, we have seen it often very quite commonly as an autoimmune etiology. So we give the patient immunotherapy therapy in the form of either methylprednisolone or IVIG and plasma exchanger, and the results are quite good, very often. So these are the few comments that I wanted to make.
Thank you, Dr. Bhaskar. Now the third talk, neuro intervention in acute stroke. I would like Dr. Gupta sir to give his perspective and what does he think, and is he doing some of these procedures in his own setup at PSRI?
Thank you, Dr. John. It was a very comprehensive talk on neurosurgery and neurology. What I would like to say is that Dr. Rahul presented a complete evaluation of back pain and including spine and upper spine and the lower spine and the back. I still prefer common X-ray as the best diagnostic procedure for any back pain. I do agree with Dr. Rahul that complete evaluation of any kind of back pain is the MRI. That is the best diagnostic procedure. And then coming to Dr. Nitin, I would like to just put one single thing, that focal seizures is something which most of us confuse with status epilepticus. So focal seizure, though they are not very life-threatening, but everybody is so much troubled by controlling the focal seizure. It is very difficult in kind of, it's challenging even to control a focal seizure. Then coming to Abhinav, I think he has given a complete talk about the stroke, about white stroke and even the red stroke. And it is important to understand that when you need to intervene, and especially in all cases of this, it is important to understand that time is brain and brain is time. So we need to understand that as soon as you have any doubts, or let's say even if a suspicion of a stroke, or if you have a suspicion of a status, then immediately refer to a higher center so the patient can be managed and his life could be saved. That's my last comment. Thank you.
Thank you, Dr. Vital. I think wonderfully shared by all three wonderful monitors. Dr. Mangla sir, you have a question, sir? I'm sure. You don't have a question, sir? All right. Dr. Podar sir. Dr. Podar sir.
Dr. Rahul, denosumab you have to give subcutaneously 6 monthly. So how long will you give? Lifelong?
10 years, sir.
10 years.
10 years studies are available, maybe beyond that.
Any side effect of denosumab?
Sir, this jaw problem, jaw fractures can happen.
Jaw fracture can occur?
Yeah. It may lead to osteoporosis or more. We have to maintain a good oral hygiene.
Okay. Besides that, no other side effect. 10 years, it can be safely given. If we give 2-3 years, then we can give the tablets.
To stop that, then you have to compensate with bisphosphonate, but the effect is not so great.
Okay.
This is what the, maybe in market data, but this is not what it is.
Dr. Gandhi sir, any question?
We come across many cases of elongated styloid vessels. And do you think any neurosurgical procedure can be done for that? Sometimes it is very irritating.
Who is personally diagnosed or bringing such patient? I think the ENT surgeons are doing the work.
That was considered to be very risky. So highly,
I don't think any neurosurgeon is doing it, Dr. Abhinav.
We have an ENT surgeon.
Sir, I am doing it quite regularly. It is Eagle syndrome as it is called. You have to do simple supraorbital X-ray for skull, and you know the sterile process. And if it is elongated, you can go across tonsil and remove it. Simple.
So, those you are doing, those you are not doing.
The thing is that it's neuralgia basically which you are doing it. It's not for the spine. So we should be very clear. It is not for the spine, it is for the neuralgia which he is talking.
And is that the stylo, which neuralgia? Okay. Right.
Ninth nerve. It is the ninth nerve.
Dr. Ashish has a question.
So what is the clear-cut demarcation for doctors to send patients, say to an orthopedic surgeon or a neurosurgeon, say for foot trauma? What is the clear-cut demarcation?
See, all neurosurgeons by virtue of their training, they are spine surgeons as well as brain surgeons. There are certain orthopedic surgeons who do specialized spine training and they become spine surgeons. But recently, a lot of centers, academic centers and teaching centers have got spine surgeons in their orthopedic profile. So many orthopedic surgeons are now turning out to be spine surgeons by virtue of their training. But till about 10 years ago, majority of the government sector orthopedic surgeons were not doing spine. So the spine orthopedic surgeons were not exposed to spine, so they don't know. They were not aware of that. They were not doing
See, the thing is that you can operate on spine, there is not a big deal. But the problem is when you have to deal with nerves, who is the expert? Who is the expert? As per the Supreme Court ruling, it is very clear. It's very, very clear. Any nerve, if it is damaged during the spine surgery, it is the neurosurgeon who can deal with the nerve. It is not the spine surgeon. He is not the specialist in nerve. So let me be clear, we can operate on tumors, on the spinal cord, we can operate on any kind of spinal pathology. The spine surgeon can only operate on the degenerative disease, let's say fixation, and in the disc disease. I am not saying that they are bad, they are very good. But the thing is, a complete surgery of the spine or the nerves is done by a neurosurgeon, and that is the whole truth and the truth.
Dr. Luthria has a question.
I agree. Just one comment. Under pressure of the moderator, I think the speaker, Dr. Agrahari, mentioned cortical venous thrombosis as a hemorrhagic stroke. It's basically a prothrombotic situation.
Prothrombotic situation. But then because of that, it is actually a prothrombotic state where because of that raised pressure in the venous system, there is a back pressure and then that leads to stroke. Hemorrhage, transformation.
Is it a hemorrhagic stroke? Cortical venous thrombosis is a hemorrhagic stroke?
Yes.
It's a hemorrhagic stroke, sir. So there is no pressure, okay? There is no pressure on monitor. This is a hemorrhagic stroke. Dr. Luthria doesn't agree with you. We say it is a thrombotic stroke.
Causing edema, causing pressure.
So we can discuss it over dinner.
And the edema causing hemorrhage.
The timeline is different, sir. The patient comes with a infarct which gets transformed into a hemorrhage.
Yes.
So that is there.
So you need to discuss it with him over dinner. Yeah. So now we have some questions and I've given 7 minutes to Dr. Tulsi sir. There is a TDS.
7 year kids.
Good evening. Any experience of your stroke post-vaccination, post-COVID vaccination? I have personal experience, Dr. Kala voluntary. Do you have any experience of that?
Hello. Yes, sir. We have seen a lot of post-COVID vaccination. We have seen a lot of stroke patients. So just after this second COVID wave, the incidence of stroke has increased, and there were some patients who had the history of COVID and 3 weeks back later they have the stroke manifestation. Some patients have taken COVID vaccine. After that, they have developed stroke. We have also seen some these are demyelinating like GBS patient. And we have also seen ADEM patient, acute demyelinating identification after vaccine.
Post-vaccine, lot of neurological complications. I like to share one patient. The individual had a stroke was the first COVID vaccine. That was ischemic stroke. But unfortunately, booster dose are also taken after 9 months. And that time he developed hemorrhagic stroke. Is that possible? It happened.
So this is tough to say that they will develop hemorrhagic stroke, but mostly we have seen ischemic stroke after post-vaccine. Most of the patients
patient were non-hypertensive, no diabetic, no, she was a doctor herself, doing all these benefits. The second booster dose resulted to hemorrhagic stroke. And she recovered, no, different. She recovered fully from the ischemic stroke by physiotherapy because we could not get the thrombolysis in time because we were about 12 hours in Delhi, but recovered by physiotherapy. But the hemorrhagic stroke is still lingering upon the right evidence.
So I have seen hemorrhagic stroke after COVID and during COVID period, post-vaccination also. With COVID, we have seen 2 or 3 brainstem strokes, hemorrhages, which were not so common before COVID.
So I want to know the experience, what is the recovery stage for those patients? Who developed statistic? How do you...
Nothing related to COVID, sir. Recovery is depending on the size of the hemorrhage, size of the stroke, area involved, how fast the treatment has been given, how good the physiotherapy is, what is the age of the patient, what was the KPS score initially. So there's not many factors, but I don't think they have a relation with the COVID.
So that I understand. That is only the stroke developed. But the recovery depends on so many factors, the age of the patient, comorbidity, and how much active physiotherapy the patient does it. But in your experience, have you seen recovery and how long it takes recovery? Can it be recovery in a longer time?
After 6 months, recovery occurs till 2 years. Initial 6 weeks are very rapid recovery, then it is slow recovery, but it can happen up to 2 years.
Sorry, thank you, sir. Thank you.
Dr. Chauhan, I still have 10 minutes.
Minus TDS.
So, those are some wonderful talks by Dr. Rahul Gupta, who talked about back pain. Nitin Kumar talked about status, epilepticus, and Dr. Abhinav talked about strokes, especially endovascular procedures. So let's begin with Dr. Rahul Gupta. So what are the red flags for back pain? Would you say this would be the subspinal cord compression or the CES, which is the chordoid syndrome? And how do you diagnose that? How do you treat it? Tell us, sir.
Any compression to the neurostructure, either it's a nerve or it's a spinal cord, is a red flag. If we can see that on MRI and if it is corroborated with the clinical signs and symptoms like involvement of the nerve in the form of paresthesias, in the form of motor deficit, in the form of dead ball involvement, or even in the form of spinal cord involvement by looking to spasticity, spinal cord changes on MRI. So all these things are red flags. Just a simple mere backache which improves on rest or by taking analgesics within 72 hours up to 7 days may not be that alarming. But back pain associated with any neurological deficit, even the first day, is alarming.
That was so fast and good and precise. Thank you. So let's talk, Dr. Nitin, regarding the status epilepticus, or popularly known as the GSSE, which is the generalized convulsive status epilepticus. So initial treatment you said is benzodiazepines, especially you prefer lorazepam, and then probably followed up with a long-acting anti-epileptic drugs, and then so if you are not able to reach the hospital, can you give midazolam? Pre-hospital?
Yeah, pre-hospital we can give midazolam because first of all midazolam we have nasal spray also, which we can give.
Is available?
Yeah, it's available. Different brands are now available, so it can be given as a nasal spray, and sometimes midazolam can also be given IM. So I think that is easy to administer when we compare to lorazepam or diazepam. So I think if the patient is having, patient has a previous history of seizure, so family member can keep a midazolam nasal spray with them, so they can keep the puffs in their nostril according to the body weight. The dose can be given. The adult dose is maximum 10 mg.
Fine. So Dr. Nitin, let me proceed. So what about for refractory GCSE, continuation period, alprazolam or propofol or phenobarbital along with intubation and mechanical ventilation is indicated here. So what about the most common reason for prolonged recovery is sedation and the continuation of the non-convulsive seizure. Clinically, it's very difficult to know what is the reason. So would you rely on EEGs here?
Yes. So EEG in these patients, first of all, when we are talking about refractory failure, the EEG helps us to monitor the patient. First of all, when we are giving midar and to the patient, I showed in my slide that we have to achieve burst suppression. That is the burst activity. After that, we have 10 seconds silence activity. Again, there will be a burst. When this burst activity has been achieved, we keep the patient for at least 48 hours. And after that, we will slowly try to prepare the infusion. And meanwhile, you have to keep the patient on 2 antiepileptics at the maximum possible dose for their body weight, so that when we beat this patient from midar, they have less occurrence of seizure.
When can you withdraw the antiepileptic drugs? If the patient is seizure free for 2 years, can you withdraw?
Sir, at least because there are different topics, at least we have seen that 3 years at least should be seizure free, 3 to 4 years. After that, we get an EEG done, an MRI done, and if everything is fine, we can try to taper this medication. But that also depends upon the seizure type, because some patients have a frontal lobe seizure, some are mesial temporal sclerosis, and in those patients, the chance of recurrence are more. So that also depends on the patient.
Very good. Let me proceed with Dr. Abhinav. So EVT and IVT are the standard of care in acute ischemic stroke.
देख लिया यहाँ से बंद कर दिया खाना लेके आ रहा इसको जवाब में तो बन ही रहेगा जब लास्ट गया इसको पीछे
Please clear this. The ideal time is within 8 hours of the onset of the symptoms. However, in certain areas where we have a stroke, patient coming in with stroke, he is well preserved, has some deficits, we do an MRI, we do not see that though the ischemic penumbra, there is some salvageable brain. We do a CT perfusion. We do a CT perfusion salvage. We look at the blood flow, and if there is a salvageable brain there, we have to go in and do a endovascular thing.
Right. So let's talk about the recent ISC and International Stroke Conference 2023 published in the GN. We talked about large strokes. If you can do EVT there, better functional outcomes are achieved, especially LVOs. Talk us through this, which was published recently in the NAGM as well, and talked about in the recent stroke conference, International Stroke Conference, and referring to the two very famous studies. Talk us through that.
So basically, the outcome from any intervention in stroke would depend upon how big the area is. That is
the angel aspect, the selective studies.
Selective study and angel aspect, they were both done to see the effect of the intervention to decide upon what to do for the stroke patient. So all of them, they have concluded that okay, we do IV TPA, then followed by endovascular therapy, and they have come down with their own criteria for which patients are good for what kind of therapy, and they have given their own guidelines for the timelines, basically, which is the...
So what was the timeline?
So basically, initially it was 6.5 hours, they have increased it to 8 hours, and then this posterior circulation stroke, they have increased it to 24 hours also, 18 to 24 hours in posterior circulation strokes. So anyways, whatever we do, however fast we do, everything will depend upon what the area of the brain is involved and what is the core, that is the larger the core,
What they said was that irrespective of the infarct, whether it's small, moderate or severe, see this endovascular procedures need to be done, especially in LVOs. So, and what about the ICH, intracranial hemorrhages? But just 4.4% in people which you did the EVT as compared to the IVT. So almost similar hemorrhage. So it's the same procedure. What do you say, sir?
Basically, yes, we have to agree to the guidelines that they come up with, but everything would depend upon the patient profile as well. The patients that we get, they are not all young strokes, they are not all free of comorbidities, they are not all good candidates for all the interventions that they have kind of proposed. So we have to individualize the treatment options.
So finally, Dr. Abhinav, talk us through the imaging of choice. Would you go for a CT or would you go for an MRI with the DWI? I believe that DWI is more specific here, though it takes a little extra time. What do you say about this thing?
So
imaging, imaging.
Ideally, if a clinical examination says it is a stroke, we have to go and do a CT, rule out hemorrhage and give the IV therapy. We can do MRI while giving the therapy. So CT would give us an idea whether there is a hemorrhage or not. If there is no hemorrhage, we have to go in and do a IV therapy. And while giving the therapy takes around 30 minutes. So we can keep the infusion on, we can take the patient for MRI, do the MRI anyways, without delaying the treatment per se.
Thank you, sir.
Thank you.
Dr. Gupta, my last question, sir. Sir, what is the difference between cysticercosis and tuberculosis when you do a CT scan of a patient? Radiologically, can you please explain, sir?
Definitely, diagnosing neurocysticercosis and tuberculosis on CT scan and MRI is debatable for ages. There are certain telltale signs which favor tuberculosis and certain ones they favor neurocysticercosis. So in neurocysticercosis, usually on CT scan we can see a hypotensive lesion. On tuberculosis also we have to do a contrast study. Sometimes we see calcification which can go more in favor of NCC as compared to tuberculosis. Tubercular lesions can be multiple conglomerate lesions, segment lake-like appearance. NCC can be a starry skies appearance which gives more in favor of NCC. So these are the differences, and then we can go for MRI which have some isointense and hypointense ring around the lesion which go in favor of tuberculosis. So these are the various signs. Still, many a time, about in 20% of the cases, we may be in doubt and we follow up these patients with therapeutic trial of ETT and see how the lesion behaves. Anything, Nitin?
Sir, but there are some patients who are HIV positive. Their CD4 sometimes is less than 50. That means they are HIV AIDS, and they are simply healthy, and they will come with giddiness and loss of consciousness. And when you do CT scan and MRI, you will not find anything. So, what will be the diagnosis? What will be the process of diagnosis that if a patient comes to what you will start? Sir, if a patient is HIV positive, his CD4 is less than 50, that means he's having HIV AIDS, and he comes with loss of consciousness. And when you do CT, there are no findings. Basically, see, now there is a rule that if a patient is having CD4 less than 200, you will start with on ADT drugs. Now it has become a rule. But sometimes you don't find any findings.
Okay, sir, first of all, if we are suspecting patient having a low CD4, in those patients, first of all, that will show that we are not getting any lesion in the brain. Okay, so for that patient, the chance of meningitis is also there. So we can get a contrast MRI done in this patient, we can get a CSF studies done in this patient to rule out infections. So that will be the next step in these patients. Because generally, if you can see that toxoplasma or tubercular lesion or NCC lesion, what can we do from this patient? And just they can be seen a little bit changes, they can see CT also. Sometimes there are some biliary diseases or some mild disease which is not pick up in CT scan to the DL from MRI zone.
Thank you very much, wonderful speakers and moderators. May I request you for a photograph? Dr. Abhinav, just for a second, for a